For today's live session, we are joined by two faculty members who will be leading on this course and taking most of our live sessions. I welcome Dr. Hueiming Liu, who is a program lead at TGI Australia and holds a keen interest in health systems research capacity, especially in delivery of patient-centered, affordable, evidence-based care to improve universal health coverage. She has led the process evaluation of two pragmatic trials of complex interventions, examining the use of cardiovascular polypill in Australian primary healthcare and the family-led rehabilitation model of Care India. She has obtained her B Honours and MBBS and worked as a medical doctor before completing her Masters in International Public Health and embarking on public health research. She was funded through the NHMRC postgraduate scholarship and was awarded in November 2018 for her PhD titled Strengthening Health Systems Through the Use of Process Evaluation. She is leading the process evaluation stream at the George Institute and provides guidance related to the conduct of process evaluation of several of our institute's collaborative projects. So, a very warm welcome, Wing. We are also joined by Dr. Menglu Ouyang, who is a research fellow at the George Institute for Global Health and is also a conjoint lecturer at UNSW. Her research field is in stroke, including acute care, clinical management, health system, and implementation science. She has an extensive experience in process evaluation in large international clinical trials as well as implementation research. She's a leading investigator for the process evaluation alongside large international trials funded by MRC and HMRC to explore the feasibility, acceptability, and implementation of evidence care. She also chairs the monthly process evaluation health system research seminar at the TGI. So, by far, I think that clearly explains that we have by far the two most appropriate people leading this course who hold vast experiences in the field of process evaluation. So, without further ado, I will hand it over to Dr. Ming and Menglu to start the session formally. Over to you both.
Thanks, Aksha. I'm just going to share the slides.
Sure.
Can everyone see the screen? Okay.
Yes.
Great. Well, thanks for joining and also register for the capacity building course for process evaluation. And thanks, Aksha, for introduce ourselves. So I'm just going through the objectives, and then I will hand over to Ming, who will facilitate and also introduce the most important part of the process of evaluation. So the whole course actually is aiming to understand why we're doing that and the process of how we're doing the process evaluation, and also how can we better articulate the research question, especially the studies we developed by answered by a process evaluation, and mostly important to how to develop a protocol for process evaluation alongside with the study. So we have 6 sessions, as mentioned by Aksha. The first session will be today. It's about the introduction of the process evaluation. And then we will talk through in the second session about the theoretical frameworks and which are the methodologies approach we use for design the process evaluation. The pre-readings for this first two sessions have been uploaded in the Moodle. So hope everyone, if you got the time, it would be good to do the pre-readings before the session. And in the third session, we're going to talk about mixed method research and also qualitative data collection for process evaluation. And then in the fourth session, we will talk about the analysis and also interpreting the outcome, the findings from the process evaluation. And in the fifth session, it's more about how can we better develop a protocol for the process evaluation. And we will also invite the panels and also people with experience from different perspectives to do a panel discussion to reflect their experience and sharing their suggestions on how to better conduct the process evaluation. And also in the last session, we will have a presentation on the process evaluation protocols you developed. And we will have a discussion. Hopefully it can improve the development and also on your understanding about the process evaluation. So here are some mandatory pre-readings for the first session. I hope you all get a time to read it.
A little bit about me. I did my PhD because I wanted to learn, but I also very pragmatically wanted to learn how to implement the polypill trial on the ground. And so I resonate with some of those lessons learned or the reasons why you're choosing to do this. Next slide, please, Menglu. So in this first session, what we're going to do is really trying to understand the need for process evaluations. And given the breadth and depth of experience in research in this group, hopefully we can learn from each other as well in the discussion and really think through, well, where can process evaluations add value to research and practice? How can we improve what we do? And so in this session, I'll cover what are process evaluations, very high level kind of explanation based on what I've learned over the years and also some insights. And then Menglu will share her kind of Interact 3 process evaluation, which is a evidence-based implementation study across many different countries in high-income countries and LMICs. And the reason for doing that, so that with the case study, hopefully over the next 6 sessions, with the case study kind of underpinning it, it makes it quite real, and hopefully it's helpful in that sense. So next slide, thanks, Menglu. So what are process evaluations? This is probably not new for a lot of you, but 10 years ago now, the definition that came out through UK MRC for evaluation of complex interventions is that process evaluations can assess fidelity and quality of implementation, clarify causal mechanisms, and identify contextual factors associated with variation outcomes. I personally think it's a bit of a mouthful, a lot of jargon, but in terms of some of those words, just unpacking it, fidelity is whether you did what you said you wanted to do, especially for evidence-based innovations. You have to stick to what the core components are so that there's actually impact. The quality of implementation, how well was it done? The causal mechanisms, I often think of the unseen things, unseen individual behavioral, organizational behavior that affects things, and identify those contextual factors in different settings. So I know we've got lots of people in India and in Bangladesh and Indonesia, but across the different states, across the different health systems, what does it look like in terms of environmental change, but also NCDs, and how does that impact on the outcomes? So often I think of it as a lot of questions of where, when, how, who, what in what we do. And of course, you can do that through qualitative research or through quantitative tools as well. When I first started 10 years ago, when I was doing, as Kansha said, I was part of the polypill trial and the family-led rehabilitation India trial. And at that time, the way we looked at process valuations was a bit kind of later on in the study, where we're trying to understand, well, we've got all this input, we've got this outcome in terms of whatever impact we were measuring, but we weren't sure what happened on the ground. And so we also looked at it as a way to understand what the black box is, what happened on the ground, and was it according to what we had set out in this beautiful project protocol, and what actually happened on the ground was the adaptation, what were people's perspectives of it to result in this outcome. So that's kind of high level of what the process evaluation tended to find according to the UK MRC guidance in 2015. Next slide, thanks, Menglu. In terms of a framework, the one on the left is the one where the blue, so context, implementation, mechanisms of impact are the key things that are meant to be looked at in the process evaluation. So context, what are the factors that shape the theory of your intervention, whatever it is? What are the factors that will affect the implementation and mechanisms and outcomes? And importantly, what are those causal mechanisms? What are the things that will make the change in the context to affect either status quo or the actual impact? And then the other side is that middle bit about implementation. So how was it actually implemented? Was there fidelity? Was it dose, adaptation, and reach? And then, as we said, the mechanisms of impact is really the people response to the intervention? Were there any mediators? And importantly, were there any unexpected pathways and consequences? We introduced something. Was there anything else that happened where we didn't anticipate that we might have to look at as well? And all of that interacts with each other to kind of affect the outcomes that you're interested in, either service outcomes, individual, or environmental change in this for the work that you're all doing. Importantly, it's very important to have a clear description of the intervention and its causal assumptions. Some people call that theory of change. So why do you think this works? What's your underlying assumptions in your context for your project? And I know all of you, including the PhD students, will have your own projects that you're thinking through. So at this first session, it'll be important to kind of think through, well, for your intervention, what are some of those? How would you describe? And what's that theory of change as we move through these 6 sessions? On the right, I guess how the process evaluation links up with health systems and policy research is that really because we're looking at context, we are therefore looking at the system's context. We're looking at a country level context, but also the broader context. So this is about health systems research where you've got that kind of hardware, right? You've got your health systems, human resources, finance, medication, technology, organizational structure, but you also have your system software, the decision making, the beliefs, the value system of your government, of your community, and that social political context. So I think the process evaluation fits really nicely because it enables that kind of systematic way of looking at local context, subnational, national, international context within that kind of social and political context. The photo above is just some of us at Health Systems Research Symposium in Liverpool. And just to highlight again the breadth and the depth of different work, and Anna Palagi's there as well, and I think she does some work. So it's a fun but complex area of research. Next slide, thanks, Menglu. I'll go quite quickly through this, but as an example, I guess, of a process evaluation, like I said, for the polypill study, this was in Australia. But when we think about, it was a simple thing of we're going to introduce, so polypills are these fixed dose combinations with statin, aspirin, and BP lowering medications, thinking that, if you prescribe one medication, that's going to improve adherence, improve indicated therapy. And that was done in primary healthcare. So this is like that figure that's to show the kind of randomization in RCT setting in Australian primary care. But when we then look deeper into it, so yes, we say the GP can, the patients are randomized either to the polypill or usual care, and the GP can decide which ones they want to, is a pragmatic trial. So even if they're allocated the polypill arm, the GP has that discretion to decide what to do over the patient's journey. And then the patient will have to fill the script and take the medication to see if there's actual changes in their blood pressure or their cholesterol. So when you think about that kind of patient journey over time, and you think about the process evaluation, then it's really breaking down to, well, contextual factors. What are some of those macro level factors? What some national policy is about CVD management? What's the cost of manufacture for fixed dose combinations? Meso level, what's the access to primary healthcare, prescribing guidelines? What is the context in which this trial is happening to have actual change in blood pressure and cholesterol at that patient level? And at that patient level, what are the patient level factors? Do they normally take their medications? Do they not? Is cost an issue for them? And so really systematically thinking through, and then also at the provider levels, what is their prescribing patterns? Do they actually believe in this medication, or do they have concerns about side effects? So systematically breaking it down and using the relevant tools, either interviews or surveys or policy analysis, to find out about those contextual factors. And then when we look at the data, is trying to understand mechanisms of outcomes. So how did that patient journey and behavior, or the providers' prescribing patterns, impact on actual taking of medications, and therefore impact on blood pressure, cholesterol, adherence, or quality of life? So a quick snapshot of one of the studies that I did in my PhD. Next slide, thanks. So that one was very much for RCT in a primary healthcare setting. But as we mentioned about how process evaluations is relevant in health systems research, I just want to flag that's also applicable across different types of complex interventions as the projects that you're all on, and different study designs, whether it's just program implementation or RCT or step wedge trial, across different types of research cycle, either feasibility and piloting or even at the co-design formative phase, evaluation of the actual effectiveness, and also post-evaluation implementation, what happened after the study. Is there sustainability? Has it been integrated into mainstream services or mainstream policy, for example? So we've got at the George Institute, there have been many different studies, but some example of those at that policy level will include like salt reduction strategy in Samoa or salt reduction strategy in China and Nigeria currently. And again, you can process evaluations of the work done there. At organizational level, you have different, I know there's some smart health interventions, sometimes at organizational level together with community health workers being implemented. So you can do a process evaluation of that model of care as well. And Menglu will talk through her Interact 3 stroke care bundle in hospitals shortly. And then, of course, at the individual level kind of strategies, such as the ATTEND trial in India, where you train family carers to provide rehabilitation. There's also, you can use process evaluations to understand the different mechanisms of impact at the individual level as well. Next slide, thanks. So across the many different studies that I've kind of been involved in or observed, and including literature reviews of process evaluations, these were some of the kind of key implications that I think I've taken over time over the last 10 years. I'm getting old. But, how can we have greater research impact to close evidence to practice gap? And I think, as we all know, that co-production, co-design of solutions for people on the ground, implementation strategies is key. You don't want to go in to address a problem that's more like a circle and then introduce a square peg as an intervention. And that can be addressed early if there's that co-design to understand. You want to have a systems lens, people-centered approach while considering the wider context. So what's the health systems looks like? What are things that you have to keep in mind? So for example, it might be good to provide guidelines, but if the health system doesn't have the relevant medications so that you can implement the guidelines, then you're going to have to look at the health system context so that it can actually be implemented. I've included the WHO people-centered integrated figure there with the person in the center, family, community, health service sector, and other sectors and country setting. Because I think as we are working across different countries, it's really important and working collaboratively with other people from different countries as well. It's important that we all have a understanding and knowledge exchange to understand the local context better and to use these iterative research cycles to understand what the local context is and what needs to be done in a feasible, acceptable way. And lastly, process evaluations, time consuming, quite resource intensive. So as you move through this, as you design your protocol, think about efficient mixed methods data collection analysis and analysis and how you can have timely feedback so that you can improve what you're doing. Thanks, next slide. So that was all very kind of UK MRC process evaluation framework focused. But as I've kind of gone through in the last 10 years, you read more about implementation science and then the term implementation outcomes comes up a lot. So acceptability, adoption, appropriate costs, feasibility, fidelity, penetration, sustainability. And that's with Proctor Enola Proctor has coined those terms, which is really helpful, I found, to think through, especially when you're looking at mixed methods research and you're thinking about reach and adoption. So if you look at the figure on the right, you've got implementation outcomes, and then if you achieve that the concept is, if you achieve those implementation outcomes, then you're likely to result in improved service outcomes and therefore improved client outcomes. My very brief kind of lay understanding is in italics. I think acceptability, do people like it? Do they use it? Does it address the underlying problems? Is it a good fit? Cost, how much does it cost to implement? Feasibility, can this happen? Fidelity, did we do as what we intended to do? Can we integrate it in our systems? And can it be done in a meaningful manner over time? And I guess I use those lay terms because sometimes I find research, we can be too caught up in jargon and it gets too confusing. But when we come back to the first principles, I think it's just simple questions that we are trying to answer. Next slide, please. So with that, I was like, oh, I'm so used to this process evaluation framework. How can I include implementation outcomes framework? And this was thanks to Professor Lisa Hirschhorn from Northwestern University. We had a chat about it. She presented it at our process evaluation meeting. And she said, actually, they are very similar. So I'll just talk this through and feel free to ask questions if it's, or we can talk through it in the next 6 weeks. But really, we're looking at context, which is very similar to kind of determinants in the kind of implementation science research world of, consolidate, for those who are familiar with some of the terms like consolidated framework for implementation research, they talk about inner setting, outer setting, what are the actors. But I think, again, it's just that systematic way of looking through all the different contextual determinants. And then you've got your mechanisms, and then you've got your outcomes. But the nice thing about the implementation research logic model on the right is that includes the implementation outcomes that we talked about before, quite explicitly as the outcomes, similarly to what the process evaluation has, but it links it back to things like feasibility and acceptability and adoption. So for some process evaluations, let's say if you're thinking about, do your stakeholders adopt your intervention, and you can count that, you could use that as a measurement for your implementation outcomes, for example. It also allows you to describe your clinical intervention, the theory of change, in the same way that the MRC one has it on the left, this one has it at the bottom. But again, I think the main thing that I have thought through and take home with me and have learned the last few years is really how to include the use of implementation outcomes in our process evaluations using the implementation research logic model. Thank you. Next slide, please. And so going back to UK MRC, they've also had more further discussions since their guidance in 2015 and 2021, they had updated MRC guidance. And this is the core figure that they've shown. And again, it kind of fits in with what we've talked about and some of the lessons learned over the years that, let's start early in terms of when you develop. So on the left, when you develop the intervention or adapt, based on the new context, do it carefully considering context, program theory with your stakeholders, looking at uncertainties, or whether you choose what is relevant in your local setting. And then you've got that feasibility and acceptability that you want to really considerately think through, and then evaluation implementation. So again, the kind of process evaluation fits across that research cycle at different times, but the core things of context, theory, and engaging your stakeholders. So thank you. So that's that very high level whiz bang kind of overview for process evaluations alongside some of the key readings. I hope that was helpful and a good refresher for those who already know a lot of the content. And for those where it's new, we'll have further discussion, but I might now hand over to Menglu, who's going to run through Interact 3 as a case study, especially her early vanguard phase, and then we'll have a time of discussion, hopefully. Thanks. Over to you, Menglu.
Thanks, Ming. Thanks for your interest to getting to know more about the process evaluation. I think the reason why you want to do the course is the same to me as well, because I got involved in Interact 3 during my PhD, and also I involved the process evaluation as a part of my thesis. So at the beginning, I was have no idea about the process evaluation, but once I get involved and developed the protocol and went through whole the process, and I find it's quite interesting and it's helped a lot to improve the trial implementation as well as to explain the outcomes. So during the whole course, I will use an Interact 3 as a kind of case study, and I will, in each session, I will talk more in detail about the design and conduction of the Interact 3, and hopefully it can bring up some more taste about the process evaluation and also bring up some practical considerations for you when you develop your own process evaluation protocol. So, so back to Interact 3, just a bit background. And it's a clinical trial based for intracerebral hemorrhage patients, which is conducted during 2017 to 2021. It's an international multi-center stepped wedged cluster randomized control trial. And the intervention is a bundle of care, which involves 4 components, include the blood pressure lowering, the glucose level control, the body temperature control, and also anticoagulant reversal. As you can see, there are multiple components in the intervention. And also we have time and also target metrics. So it's a quite complex intervention based on the clinical trial. And in the right side of the figure, actually, it's the study design scheme of the step-wedged trial. So as you can see, all the site hospitals has been randomized to 3 groups, and all of them have been started as control, which is the Eurocare at the beginning, and then they transfer to a care bundle depending on the randomization. So that means once they change from the Eurocare to the implementation of the care bundle, they have to deliver the care bundle as a kind of routine practice in their hospitals, because every eligible patients who get involved in the trial, they will receive the care bundle as a Eurocare. So the aim to do a process evaluation alongside with the interactive trial is, first of all, to optimize the implementation and understand whether there is any barriers or facilitators, especially at the early phase of delivery the care bundle as an intervention. And also the process evaluation will help to assess the quality of the implementation of the care bundle, which will help us to explain whether there is a variations of the outcomes. Is that caused by the delivery of the care bundle, or it's caused by something else, such as the mechanisms or something like the contextual difference. And within the Interact 3, we used 2 theoretical approaches. First one is the MRC guidance, which Ming has briefly talked through it at the beginning. Which we use it for measure the implementation outcomes of the care bundle. And we also used a normalization process theory, which is to understand how the care bundle has been embedded into the routine practice, especially for those sites which entered into the intervention phase. Because as mentioned before, the study design required every hospital to deliver the care bundle as a routine practice once they get involved in the intervention. We will talk through the theoretical frameworks in the second session, and we have some pre-readings about this. If you are interested, you can have a read at the end of the session. So this is the implementation research logic model as mentioned by Ming. So it developed based on the rationale of the Interact 3 trial. As you can see, the context factors, which also called determinants, have been listed here, which included about the settings and also the intervention components, which is very complex, have multiple components. And also, as you can see, for the study design, it's more about change of the organizational level to change the local protocol and deliver the care bundle as a routine practice. And we used multiple implementation strategies to collect the data to measure to evaluate the process of the care bundle delivery, and also where is any change at the organizational level which impact on the implementation. And also we used normalization process theory to understand the mechanism of change. How is the care bundle integrated into the routine practice? And for the implementation outcomes, we followed the MRC guidance, looking at the fidelity and acceptability and other implementation outcomes as mentioned. And also at the final outcomes, we're also looking at whether there is any adherence change according to the care bundle delivery, whether there is any knowledge and improvement about the intracerebral hemorrhage management. And overall, we want all the changes being impact on the patient outcomes, which is functional recovery after the intracerebral hemorrhage. So we used a mixed method approach to collect the data, include quantitative, such as the focus group discussion with the clinicians and also with the patients. We also collected quantitative data, include the observational records and also the patient's case form, as well as some operational data, such as the monthly report of the performance of the sites to understand their quality of control. So in the vanguard phase, we conducted in China the process. We did interviews with 26 clinicians and also two focus group discussion, one with the principal investigators, which is at the high level of the managers, and also one with the operational team to understand their perspectives and also the implementation of the care bundle. And we found that the care bundle was delivered and it's quite acceptable by the clinicians because they thought its benefit to the patient's recovery. However, there are some difficulties reported at the beginning of transfer into the care bundle phase because there are some kind of conditions such as the patients, if they are aggressive or in an acute phase, it's very difficult for them to reach the protocol, the care bundle defined targets. There are some barriers also be mentioned from the in-process evaluation, such as delayed process and also in some of the context factors, such as a short of the medication supply and also because there is some like staffing resources challenge and because we have to include different components of the care bundle. For some participating departments, they don't have expertise in using the insulin to control the glucose level, which is also another context factors we find it's a challenge to deliver the care bundle. However, we also identify some facilitators to better implement the care bundle, such as to optimize the workflow with existing resources, and also having a site champion to delegate the team to work together to better deliver the care. And also have additional trainings to help the clinicians to understand the benefits of the intervention, which will help them to change the behaviors to deliver a better care bundle for the patients. So the implications of the process evaluation that we did in the vanguard phase actually helped us to determine the facilitators and the barriers, which further guide us to improve the implementation of the care bundle in the later phase, which is spread into the other countries. We did some additional trainings and guidance to the sites to help them to understand the rationale of the care bundle, and also to help them to enhance the delivery of the care bundle. We also identify the champion sites to share them experience to the other sites, just to make sure they have feedbacks to each other and share the useful how to better implement the protocol. And also we have some suggestions to the operational team to better improve the quality of implementation, to help the sites better improve the quality of implementation, such as we reported the results from the process evaluation to the project operation team, and also presented the results, so especially the barriers and facilitators. We discussed it with the investigators in a national investigator meeting, which trying to address the barriers. And after that investigator meeting, actually we find there is a very good improvement in the care bundle delivery, and we measured it by whether they have achieved the targets and time that we have in the care bundle protocol, and we say that they have a very good improvement in achieve the target, and also they have an increase of 9% of achieving the targets from our monthly report that is generated from the operational team. So overall, I think the implementation of doing the process evaluation is at the early phase would be very helpful to actually improve, like ongoing improve the implementation of the intervention, and also help with the future trial design. So here are some additional reference for the interactive process evaluation. So if you are interested, we will put it as additional readings in the Moodle. And also we will have much more detailed design and also conduction and data collection about Interact 3 as a case study. So that's what I want to share about Interact 3. And now I'll hand over to you, Ming.
Thanks, Menglu. Yeah, and so just to wrap up, 3 key messages: process evaluation assess the fidelity, quality of implementation, clarify causal mechanisms, and the contextual factors that can be used to optimize implementation, as Menglu has shared. And also, if it's done later on, then it's really looking at a possible explanation about your variation of outcomes by looking at mechanisms, impact, and implementation and contextual differences. But more importantly, so that you kind of have this continuous learning cycle to inform future studies, implementation, and adaptation of the work that you do. Next slide. And and that's it for this first session. I hope that was helpful.